Hello, my name is Jennifer Wooten, and I will be teaching this lesson today on eating disorders in adolescence. I appreciate you guys being here today. What we're going to start with today are just a few facts about anorexia nervosa and bulimia nervosa. If you'll direct your attention to the PowerPoint up here, you'll see that 3% of adolescents aged 13 to 18 are diagnosed with an eating disorder. Girls are at higher risk than boys for eating disorders. And a family history of either eating disorder or any other mental illness does put an adolescent at higher risk of being diagnosed with an eating disorder. You guys were assigned after the last class to read the article Family-Based Treatment of Eating Disorders in Adolescence, Current Insights. I'm glad to see several of you have brought that with you today. And I just want to kind of open up the floor. What did you guys think about this article? Things that stood out, things that you had questions about. Go ahead, anybody. Feel free to start.
The high rates of eating disorders among mainly adolescents versus adults.
Okay, so Clint's saying that mainly the high levels of eating disorders among younger people rather than adults. Did you guys see that as well? Same thing?
Yes.
Okay, what else?
The 3 phases in the second page dealing with the steady weight gain and eating disorder has begun to recede.
Okay. All right, you want to explain that a little bit more, Alex? So you're saying there were 3 phases. What were those 3 phases?
Phase 1 continued until there was a steady weight gain.
Okay.
And then phase 2 developed into a gradually giving responsibility over eating back to the adolescent. And in phase 3, there was a review of the adolescent's development, and a therapist ensured that the family is back on track with the normal family life.
Okay. And now why do you think that was important? What do you think was so important about that point that you brought out?
To show the family-based treatments for anorexia nervosa. That just caught my attention on how they would control and fix that.
Right. They just kind of bring in the whole family.
Yes.
Great. Bailey, what about you? What did you notice?
I thought it was interesting how there's not just one way to go about family-based treatment.
Okay.
And for most, or not most, but for some even, family-based treatment is not better than individual treatment.
Oh, okay. Good point. I like that too, because we're going to get to that a little bit later in the lesson as well. Is family-based therapy the way to go? We are going to find out today that this is the top evidence-based treatment. This is the number one go-to for adolescents with eating disorders. But are there other options? Are there circumstances? So I want you guys thinking about that throughout the lesson. I don't want you just getting it in your head that because this is the number one evidence-based practice, does that mean it's going to work for everybody? What do you guys think about that?
I think it should be individualized to the case.
Okay.
Depending on which one is more effective to the person involved suffering from the illness, what are they more comfortable with, what produces the best and most efficient outcomes.
Okay. Good point.
It also says here that there was a study where 40 therapists were interviewed, and it says that although that over 80% felt the manualized script was well written, not one of the therapists practiced the treatment directly to the manual.
Right. Okay. That's a very good point too, Bailey. I appreciate you bringing that up as well. And we have seen that. I know you guys, where you are in your program at the moment, you've seen other forms of therapy used for other mental illnesses. And so you guys already are pretty well aware that it's difficult to just say, this is what you do, this is what you do, this is what you do. You're right, Clint, you brought up a good point. It has to be individualized to the patient. So you have to be willing to maneuver on that. And Bailey, that was a really good point you brought up. Anything anybody else wanted to add about the article before we move on? All right, good job. I'm glad you guys read that. Did you find it informative? Did you find it helpful?
Yes.
Okay, good. All right. We're going to talk now a little bit about the signs and symptoms of anorexia nervosa and the signs and symptoms of bulimia nervosa, because those are the top 2 most common eating disorders in adolescents. And you are going to notice as we go along that there are some similarities and there are some differences. Anorexia nervosa, number 1, refusing to maintain a healthy weight. You'll see that they also have an extreme fear of gaining weight, constant dieting. It's not just like, oh, I'm going to diet and then it kind of falls off, kind of like most of us do. But this is a constant diet, constant obsession almost with dieting. Excessive and compulsive exercising. Now exercise is good. I'm not saying exercise is bad here, okay? But this is to the point where it is negatively affecting their health. Avoiding food or denying hunger. So they might not eat. They might say, oh, I'm not hungry. Use that as an excuse a lot. How many of you, especially, have you ever been sitting in church and you hear the person beside you hear their belly growl? I think that happened to me this morning. So that would be, you know this person's hungry. You know this person hasn't eaten. And they're saying, you offer them food. No, I'm not hungry. I'm not hungry. So that's, a little different. Developing rituals. This can look a lot of different ways. One of the rituals that they might move their food around on their plate a lot. They might kind of hide some of their food under other food. Cut it into really small bites. Excessive chewing. There are a number of rituals that can come along with anorexia nervosa. Have any of you guys witnessed these in anybody, in family members, in friends when you were younger? Have you ever noticed these symptoms in anybody?
I've seen pocketing a lot.
Okay. Explain that to us.
Basically, they eat the food, or at least simulate eating, and they pocket it in their cheek almost as someone would be chewing tobacco. And then when they're done with the meal, when they dump their tray, they spit the food out too. Okay.
Right. And that's something that's more common in adolescence because if you think about it, when you're an adult, you don't really have somebody monitoring what you're eating, when you're eating, how much you're eating. But as a child, we do. Parents tend to monitor. Teachers, that kind of thing, tend to monitor who's eating, what they're eating, because that's a parent's job. That's the adult's job. So that's a good one, Clint. That's another one to add. All right, let's look now at the signs and symptoms of bulimia nervosa. You'll see a lot of them are similar. One difference, they might eat a lot at one time. They might find it difficult to stop eating. That vomiting comes along with bulimia nervosa. And so they might spend excessive times in the bathroom. But you will see that excessive exercise is still a symptom of bulimia as well. Fear of gaining weight. Again, we saw that in anorexia. What else do you notice about these symptoms? Any similarities or differences?
It says, I don't know if you would still have shame after eating with anorexia, but here you have listed that they have guilt, shame, or anxiety after they eat.
Yeah, absolutely. I agree with you, Bailey, especially the anxiety part. It seems that anxiety surrounds eating in general for both of these disorders. That's a really good point. What else?
The excessive exercise is repetitive on both sides of the case.
Yes, absolutely. Excessive exercise. And again, why would you think that excessive exercise? Because we're talking about eating. We're not talking about exercising. So why would excessive exercise be listed as a sign or a symptom of these disorders?
Because with both disorders, their main goal is to lose weight.
Okay.
And to be excessively thin.
Okay. Good point. So if that's the case, then treatment would be to maintain a healthy weight, yes. Right? If you're excessively exercising, it's difficult to maintain a healthy weight, right? Good job. Good point, guys. All right, I've got a video that I want to show you all. Oh, I'm sorry. Before I jump over to the videos, let's talk a little bit about what we're going to learn today, okay? So after this lesson, you guys will be able to describe what eating disorders are, summarize the steps of family-based treatment and cognitive behavior therapy, and examine and compare family-based therapy and cognitive behavior therapy. All right. Before we move on to the videos, I'm going to give you guys a couple of papers. You're going to have some guided notes for both videos, and there's also going to be there will also be an agenda given to you guys, okay? This will just kind of help us to keep our time. And you can just follow through the notes and we'll discuss the video afterwards. The first video we're going to watch is on family-based therapy.
Hello, my name is Dr. Sim. I'm a clinical psychologist in the Department of Psychiatry and Psychology at the Mayo Clinic. Today I want to talk to you about family-based therapy for anorexia nervosa. Family-based therapy is an evidence-based treatment for adolescents suffering from the illness. What we know about anorexia nervosa is it's a pretty serious condition, and it really involves fear of weight gain. It's really the hallmark of the disease. The challenge with this fear of weight gain is that what we know is people cannot recover from the illness without gaining weight. We also know that this is an illness with a very serious, significant mortality rate. It can become chronic, it can become intractable, it can really diminish patients' quality of life and their overall health. So we have to take this illness very seriously. Essentially, family-based treatment sees the adolescent as not capable of really making good choices about their health, and they need their family to support them in order to recover. The treatment really mobilizes the parents to help with the refeeding of the child, knowing that the kid cannot do it on their own. They really need help. Essentially, individuals with anorexia nervosa experience a phenomenon called anosognosia. This is where individuals do not know that they're seriously ill. They are not concerned about the low weight and have a very hard time doing what it takes to get better. The other challenge with anorexia nervosa is that the symptoms themselves, controlling one's eating, weight, and shape, tend to be what we call egosyntonic in nature. So essentially, this means that the symptoms are consistent with the person's very positive view of themselves. We will see kids who are the valedictorian of their school and have this amazing accomplishment, but if they gain 5 pounds, they feel absolutely terrible about themselves. And to the contrary, when they lose 5 pounds, they feel very good about themselves. They think that they're doing something very good. So obviously, this makes gaining weight a very difficult endeavor. It's something that the patient does not want to do. So traditional psychotherapy, where we work with the individual to help them take action to make change in their life, is not typically successful in an adolescent with this condition. So the other challenge with anorexia nervosa is that these individuals are quite malnourished and emaciated and are not capable of thinking clearly. We know that a lot of the symptoms of anorexia nervosa are exacerbated by starvation. In fact, a lot of what we know about anorexia nervosa comes from a study that was done way back in the 1940s. It was actually done up at the University of Minnesota. The goal of the study was to understand the effects of human starvation. So they took normal, healthy male volunteers, and these were all college-age men with no history of any mental health problems, and they were physically fit, normal weight, and they had them lose 25% of their body weight in several months. So they put them on a severe calorie-restricted diet, and they found very quickly into the study the men started showing changes in their behavior. They were irritable, short-tempered, they became very withdrawn, they lacked motivation. 2 of the men during the study were psychiatrically hospitalized. The men became very preoccupied with food. They would cut their food up into small bites. They would dilute it with water to make it last longer. They would read cookbooks in their spare time. They became weak, very disabled. And these, again, are a lot of the symptoms that we see in anorexia nervosa. Interestingly, towards the end of the study, the men were refed. Their calories were increased systematically, and then eventually they let the men eat whatever they wanted in order to get back to their former weight. And they found that once they were fully weight restored, all of the symptoms resolved. So we need to apply the information from the study to anorexia nervosa. We need to see that food is the medicine, And so really, refeeding and full weight restoration are key, are central to helping people with anorexia recover. We need then to get parents involved because they know their child best. They are really the experts, and they can help these kids get better. And we do see them get better with this treatment. In fact, the outcomes are quite promising. We know that the majority of younger adolescents with a short history of the illness get better. They have a very good outcome. And 5 years later, the research says that they tend to stay better. So there's a very low relapse rate. So this is essentially the treatment of choice. So again, I'm Leslie Sim, and thank you so much for listening.
All right. So, what did you guys think about that?
I think she was spot on with the research articles that we reviewed.
Okay. It kind of backed up what we read.
Absolutely.
Okay. What else?
It restated the. Hang on, I'm trying to find a note again. I lost it. The rituals again with cutting up small.
Okay. Yeah. So she reiterated a lot of the symptoms that we discussed earlier in the class. Okay.
She also said that it was the treatment of choice.
Right. The treatment of choice. All right. So I'm going to play devil's advocate though for a second. What was her reasoning for family-based therapy? Who did she say played such a significant part in that initial step? First of all, what was that initial step? Do you guys remember? Refeeding. Refeeding was that initial step. Who did she say played the most important part in the refeeding? Do you remember in the initial?
Parents.
The parents, right. Why?
Because they know what the kid eats, their eating habits.
Exactly. She referred to the parents as the expert of the child. So let me play devil's advocate here for a minute. This is our treatment of choice. What about foster children? What about children in group homes? What about children who don't have parents? What do you guys think about that?
That throws back to what Clint stated earlier about individual treatment based on the patient's family outcomes.
Right. It's not, even though it is the treatment of choice, it's not going to work in every situation. So that's why I wanted to bring in a second therapy that we could consider for adolescents as well. Now, you guys, I know, are probably pretty familiar with cognitive behavioral therapy, but this is a little bit different. This is going to be cognitive behavior therapy that is based on, or that is for eating disorders. And I'm going to skip ahead because some of this is just basic CBT that you guys already know. So we're going to skip ahead to the part that hits directly on eating disorders, all right? And you guys have guided notes for this as well if you want to use that to help you follow along with the video.
Cognitive behavioral therapy is the topic that, the treatment topic that I thought most interesting. As defined by Ben Martin, as CBT is a short-term, goal-oriented psychotherapy treatment that takes a hand-on approach to problem solving. CBT's goal is to change patterns of thinking or behavior that are behind people's difficulties, and so they change the way they feel. CBT helps individuals become more aware of their negative thoughts that they have and be able to respond to them in a more effective manner once they're thinking more clearly. There are 4 very basic steps to cognitive behavioral therapy. Those affected identify their troubling situations or conditions in their life. They become more aware of their thoughts, emotions, and beliefs in those situations. Identify their negative thoughts and accurate thinking concerning those problems. And they start to reshape those negative thoughts and inaccurate thinking to more positive thoughts. Farrer, Cooper, and Safran stated that eating disorders and cognitive behavioral therapy are a perfect match. This is because eating disorders are essentially cognitive disorders. So if you change the way you're thinking, you can change your life. CBTE was designed as a treatment for adults suffering with eating disorders. And it's designed to be equally suitable for men and women suffering from eating disorders. Awareness is key. The National Eating Disorders Awareness Association focuses on public understanding of eating disorders, the causes, the dangers, and the treatments. I found their website very informative on how eating disorders are formed, the awareness, and how to get help and how to help others. You can check out their website, and on their website, they have a screening tool where they say 3 minutes can save a life. It just takes 3 minutes. You can answer the questions. You can find out if you're at risk for an eating disorder and how to get help. Eating disorders have the highest morbidity rate than any other mental disorder. Early detection is key to saving the lives of those we love and ourselves.
All right, so I want you guys to take just a minute and discuss with your partner your guided notes that we just went through for both family-based therapy and CBT. I want you guys to pick out just a few things that you would like to bring to the class, that you would like to discuss. Something you noticed, something that you want to know more about, those kind of things. So I'm going to give you guys about 1 minute to do that, okay? If you want to just discuss with your partner.
So what do you think as far as the mental aspect of this? Yeah, I agree with that. I agree. I didn't realize that either, but it is. It's according to the video.
The situations of conditions of life.
So that would be the first step, right? This is the second
They identify
step.
their thoughts and then reshape them.
Right, right.
They identify
That would be the
their
third step.
thoughts and then reshape them.
And that's the fourth. That's a cognitive to CBT. Right, right. Not the family-based. Cognitive. Right. Yeah, we just watched that. The eating disorders are essentially blank disorders. Right. Bingo. So what about the kids that are in the group homes and the ones that are in foster care?
And
Right, they do that, and it is common. You're right,
both of these equal to
but you know it's a problem. But you've got to still address it.
Cognitive behavior therapy.
Yeah.
And it also says that eating disorders are cognitive.
right.
All right, you guys about ready to bring it back? All right, so what did your group come up with, Bailey and Alex?
Them. Cognitive. Okay. So, with cognitive behavior therapy, they are identifying their thoughts and troubles, and then they're trying to reshape them.
Okay. How is that different from family-based therapy?
With family-based therapy, you're trying to reshape your habits.
Okay.
By using the whole family as help, but with cognitive behavior therapy, you're trying to reshape your patterns of thinking so that you don't tend towards those habits.
Okay. So, give me some ideas that you guys had of. I overheard you guys talking a little bit. Tell me some ideas of when you think CBT might be more beneficial than family-based therapy for adolescents.
CBT would be more beneficial, as we said before, if you don't have a good family unit or a steady family unit. But also, I think if the person with the eating disorder has such high anxiety that having other people brought into their therapy might be detrimental.
Okay. That's a great thought. That's a really great point. What about you, Clint? What about your group?
Well, we agreed that the original video said that family-based therapy might be more effective. But what's interesting is, as Bailey said, the origin and epicenter of eating disorders is a mental aspect. So when you are doing cognitive behavioral therapy, you directly address the cognitive standpoint of that. Yet the family-based therapy is still very effective in some situations. So we thought that was very interesting, that there really is no loser in this game as long as the patient gets their help. Right.
And if you might remember too from your article that you read that family-based therapy, the main goal is not necessarily, they're not worried about where the eating disorder came from. They're worried about, let's get this healthy weight and let's maintain this healthy weight. They're not worried about where the eating disorder came from, whereas cognitive behavior therapy focuses more on the origin of the disorder. What do you guys think about that? Do you think it's important to know, or do you think it's not important to know?
I think it's important to know because if you know the origin of it, then you can avoid triggers down the line.
Okay. So maybe long-term health is what you're talking about? Okay.
I completely agree. Family-based therapy, it's not that it's an unknown, but you're addressing the root cause with cognitive behavioral therapy.
Yeah. You know, and one thing I found interesting, one of our earlier slides, I mentioned to you all that a history of any family mental illness puts a adolescent girl at higher risk for an eating disorder. So that to me says, hey, it might be important for us to know what's causing this.
Yeah.
You know, there might be something underlying. And Bailey, I think that's what you were hitting on with what you were saying there. Great job, guys. All right. So to end for today, I just kind of wanted to wrap up. We already have wrapped up a little bit about what the common signs and symptoms are between anorexia and bulimia. We have kind of talked about the similarities and the differences between the two therapy types that we've discussed. We've discussed different situations where either or might be useful. But I also wanted to leave you all with this encouraging verse. It's one of my favorites. It's 1 Samuel 16:7, and it says, "For the Lord does not see us as man sees. For man looks at the outward appearance, but the Lord looks at the heart." And I feel that is pretty relevant to what we've discussed today, because the basis of these eating disorders is what they see on the outside, and that's not necessarily what we need to be concerned about. We just need to be concerned about what's on the inside, just as the Lord is concerned about what's on the inside. All right, so before the next class, I will email you guys. You will have another article that I want you to read and come prepared to discuss. And I'll tell you what's helpful. If you might just write down a few ideas. If you could just pull 3 things out of that article that you want to discuss, something that's meaningful to you, something you can relate to, something you want to learn more about, just like we discussed earlier today. Okay. All right. Thanks, guys.